Hello, everyone, and thanks for joining us for this concurrent session on humanitarian development nexus and fragility and conflict. My name is Ekoti Mensa. I am with the Global Planning Committee for this conference, and I'm pleased to meet you all. So basically, the concurrent session brings together diverse professionals, experiences, and perspectives, examining new research evidence, strategies, and practices, and engaging with peers on emerging issues. We encourage all of you to actively participate, ask questions, and share ideas with our presenters. Please use the chat box to type in your questions and comments during the presentation. If time allows, a couple of people will be allowed to use their microphones to also participate after each session. In the meantime, you can do also share your questions via the chat box. Okay, so our speakers for today, first on the list are Sona Sharma, Komokek Bonnie Robert, who are all from the Action Against Hunger organization in the United States. I hope I got that correct. They will both be speaking on the topic social and behavior change, small tactics with a large difference. So without much ado, I hand over to Sona from Action Against Hunger. Thank you.
Thank you, Echo. I do see my colleague, Bonnie Robert, also on the call now. He's joining from Kyangwali, and I'm based in India, but yes, we work with the Action Against Hunger USA. Before we start, may I request all participants to look at the chat box, the link sent in the chat box, and please list down your names there. That will help us, keep a record of all of you who have attended our session today. So thank you for doing that. I will share my screen and start the presentation right away. I hope you can see the screen. Okay, so we are today going to be talking about our experience in the Kyangwali refugee settlement in Uganda, the social and behavior change intervention that was implemented, and our focus of the presentation is on small tactics that have made a large difference in the WASH program that was implemented. I have with me my colleague Komake Bonnie Robert, who has been part of the team implementing it. He's the he's the WASH officer for the program, and I'm hoping that the internet helps us and stays stable there. It's not easy to get internet access in Kyangwali. I think without taking more time on this, I will first hand over to my colleague to take you through the first few slides. Bonnie? Bonnie, are you able to unmute yourself?
Yes, Anna.
Yes, please go ahead.
Yes, thank you very much for this opportunity. I would like to give thanks to the core group of health practitioners that has given us opportunity, the team from Action Against Hunger, and especially from Kyangwali Refugee Settlement to join the team. Thank you so much. I hope I'm not mistaken, Heiko, our facilitator for today. To begin, I would like first to begin by highlighting the Kyangwali. Kyangwali is a refugee settlement, which is in Kube district in Western Uganda. It hosted a refugee of an estimated number 123,000 refugees, and these refugees are from Congo. They reached Uganda due to humanitarian crisis, which is in Congo. I think most of us are aware of that. This estimate is by April 2020, the estimated number of refugees which are in Kyangwali refugee settlement. And we go to another slide, unless there's any other question. So brief, that is Kyangwali. Before we go into details of our experience sharing on the SBCC, especially under EcoWASH projects, we would like to just see a clip of a video for a testimonial of the people who are going to speak themselves. I think the facilitator and the team, we can have some 2 minutes to watch and listen. Thank you. Hello?
Yes, hello, we can hear you.
Oh, sorry, it's not playing Sona. Hello, Sona?
Hello, can you not see the video? Let me share my screen again. I'm sorry for the interruption. Sorry, these we are still getting used to the technologies, and I'm sure it'll work this time.
Ambayo action against hunger walifanya hapa ilikuwa mingi na mimi pia nilikuwa kati yao. Tulikuwa na radio talk show. Mimi nilienda walinipeleka kama Hygiene Promoter kule kufundisha. Kwa nyingine ya drama show, michezo. Mimi pia nilikuwa moja kati ya watu ya hiyo michezo, kuandaa michezo hiyo.
Against hunger aliletea sema mafundisho tofauti. Mimi nilikuwa nafanya sana. Nilikuwa nawa mikono yangu na kutengeneza choloni yangu ikuwa mzuri. Na mimi nasafisha sahani yangu naweka nafasi mzuri. Na maji. Na maji vile mimi naweka mzuri na mavi. Mimi nachunga mavi mzuri isionekana.
Walifundisha sisi juu ya usafi. Mambo mbele mafi ilikuwa ndani ya mwingine, mafi ile ilikuwa teremuka ndani ya maji, na sisi pia tulikuwa kunywa maji hii.
Badiliko iko sahi, niko na afya mzuri. Na watoto iko na afya mzuri. Ugonjwa haiko, juu nilikuwa napoteza saa yote pesa kuhusu kuhara, njoo ilikuwa kuhara ilikuwa sana. Sasa saa hii kuhara kuna. Ile njoo mimi naona tuko na afya mzuri. Hii mabadiliko kubwa.
Enye mimi nilipata toka STF, nilitaka wa STF waendelea kufundisha hata wa jirani zangu, pia wajue mafundisho yenye kama mimi nilipata, watoke kwa hali ya mchafu, warudi kwa hali ya mzuri.
Mimi kitu cha kwanza nashukuru kazi ya STF sana.
Maneno iko kwanza ni kuwashukuru sana. Nashukuru STF, nashukuru Eco ambao waliingiza pesa sababu kazi walifanya hapa ilinigeuza mimi.
Okay, so we go ahead.
Yes, thank you very much for the facilitators and the team in room 5 to actually hear the testimonial themselves. To continue with the highlight of the projects, Action Against Hunger implemented the WASH projects under funding of European Civil Protection and Humanitarian Aid Office, It was funded under a consortium led by the Danish Refugee Council. As I stated before, the project started in February 2019 to April 2020, about 15 months. However, due to some challenges, the real SPCC took only 9 months because of identification of beneficiaries. These beneficiaries, Action Against Hunger, targeted beneficiaries for construction of household latrines, and these beneficiaries have to be identified through UNHCR. So we could not do it on ourselves. According to the baseline that was done in Kyangwali settlement, it was 43. It indicates 43% of the household having handwashing facilities, and 32% of the household could list 3 times of critical moment of handwashing. So these were the gaps around the social behavior in the settlement, and this informed the basis of the projects under ECHO. So we could go to the strategy which we developed as per the baseline identified. Yes, our strategy, the objectives of the strategy of social behavior change communications under ECHO-WASH 8 projects funded program, it was to promote adaptation of appropriate hygiene practices by use of latrines, safe disposal of feces, handwashing at key critical times with soap and ash, and safe drinking water handling. And this, to achieve this, the strategies were at the level of 3 categories: the community level, the parents of children under 2 or 5 years below, and household level. Where community levels, we were using the mass media, radio, talk show, drama, and video. This one targets all people who listen and who participate in the drama. And the parents of under 5 or 2 years, we use dialogue meetings, peer group sessions. As you see, the drama is clearly seen there. And at household levels, we have follow-up by hygiene promoters who regularly follow up after 2-3 weeks to follow up the commitment made by the households during the various sessions made above at level 3. So another slide. All our strategies on the behavior change, it was especially on the key principle of the 4 parameters under behavior change, which is the encouragement. So all the programs were engaging dialogues. This one is engaging the community and the leaders in the dialogues to create space for sharing and encouraging discussion about challenges and solutions as part of adult learning cycle. At the same time, the strategy we use to promote positive role models. This one promotes the parents, the mother, the children through the testimony, the drama. You saw the testimony we had, and the video also had the drama. Those are the testimony, and we are locally produced from the settlement here. We support changes. Under this activity, we support the process of change now. Regular support visit by hygiene promoters, health experts, giving options to users, because there is also construction, because we have to use locally available raw materials, some materials. We call our regular visit is to find way and help people to solve problems that affects their way of moving forward towards change. So we provide technical guidance, and all this we encourage them, but positive encouragement. You know, adult learning is creating emotion. So we encourage them through positive, creating emotion where they have the emotion on nurturing and caring feelings of the family, of themselves, but not fearing. So all this promote adaptation of new practices, not only health benefits. We encourage beneficiaries to make them feel confident. Those are the 4 principles of social behavior change, which were actually our promotion is triggering around. Yes, may we? With this, I would like to hand you over to Sona to take over from here. Thank you so much for taking the time to listen for us, Sona.
Thank you, Bonnie. So now's the time for a little interaction with you. Let us hear from you. If you can take your phones or even on your laptop, go to www.menti.com. You will be asked for a code. You can enter the code that you can see on the screen, which is 9653415. And please answer the question, which activities or channels do you think are the most effective for behavior change? You can give up to 4 responses. You need not give all 4 responses, but you could give up to 4 responses. So go to www.menti.com and enter this code, and let's see what you think are the activities and channels that are most effective for behavior change. I will stop sharing now because I will go back to go to menti.com so that we can see what your responses are. Okay, I already see a lot of responses coming in. So here we can see some of the responses: social media, radio, mass media. And I think the ones that are more prominent are the ones that more people have written about. So obviously social media and radio seem to be more prominent here. There's two-way communication, peer group discussions, religious leaders, one-on-one education. I think most of the other responses are either 1 or 2, so they are much less than the other than social media and radio. So the winners really seem to be social media and radio here. We now have about 15 people on this who have voted already. I think we've got our winners clearly here: radio and social media, but also participatory group session, two-way communication, education systems, and community dialogue, mother groups, a whole lot of options here. So let me just go back to the presentation then. I hope you can still see my screen. So with that, thank you for participating in that. And it's really, I think the question was a bit of a trick question there, because what I asked was, which are the channels or activities that are most effective for behavior change. I think what also matters is how those activities or channels are used and implemented. And I think those are the tactics that I would like to highlight about the program that was done in Uganda. Before I go on to the slide, if you have any questions in between, please do feel free to write it in the chat. We will have a little bit of time, hopefully, for the questions and answers, when you can even unmute yourself and ask the questions. But as you think about the questions, please put them in the chat. So I think the set of channels and activities that were chosen for this project was, as Bonnie informed earlier, based on a barrier analysis and based on the formative research that was done. So drama shows, community dialogues, radio talk shows, home visits, and video shows were organized. But I think that the critical part here is the different arrows, the web of arrows that you can see here. So every activity was linked to the other activity, to at least two other activities. And so which actually created a synergy, and people got more opportunity to see the messages. And when we evaluate the communication impact, it is the OTS, or the opportunity to see, which is a critical measure. I think here I'd like to point out two specific examples of the tactics that were used. The drama shows and actually the radio talk shows and the video shows. So the radio talk shows included a panel which had the hygiene promoter, it had the community leaders, in addition to the health experts, and the community members could call in to ask the questions and clarify doubts. So they had the facility of a live call-in as well. So the community was engaged thoroughly in that process as well. For the video shows, I think the unique part here was that even in the production of the films for the video shows, the community was engaged. So at every stage of the production, so that there were the drama group members were engaged in writing the scripts for the video films. There were local actors who were selected for the film in addition to the drama group members. And it was pre-tested with the community a couple of times before finalizing the films. There were 2 films that were produced, and later on there were video shows. And every activity that was implemented ended with a group discussion. So if it was a drama show, it ended with a discussion with the community members and motivating them to make commitments on which of the behaviors would they adopt. So it was very action oriented. And these commitments were then followed up by the hygiene promoters during their home visits. So I think those were the few things that I wanted to highlight as important tactics that made a difference. And when COVID came about, the team quickly adapted to the WASH communication for COVID-19. There were special radio talk shows which were aired on COVID-19 with a panel of experts, as well as with hygiene promoters and community leaders. Similarly, there was a live call-in, and the queries and responses were documented for further dissemination as well. Just to talk about some results, while the evaluation, there wasn't a specific, quantitative evaluation of the SBC intervention, but there was a qualitative assessment that was done, and the post-distribution monitoring survey also included aspects of finding out what the communication impact was. So as we can see, about 97% of the respondents had received information about hygiene and sanitation practices through different channels. And this was corroborated by the qualitative assessment, where the knowledge levels was very good on the 5 critical behaviors that were promoted by in the SBC strategy. And we can also see that 84% of respondents reported that they had received the information from the ACF staff, and this is primarily the hygiene promoters. And about 45% had attended the video shows, of which 96% liked the videos, and 96% had participated in the group sensitization sessions. And this was evident in the qualitative assessment, where hand washing at critical times and safe disposal of child feces were top of the mind recall from the video shows and drama shows. And disposal of child feces was a behavior that was reported easy to adopt. And there were direct observations that we did during the qualitative assessment, which also revealed that it is being practiced. I think with that, I will hand it back to Bonnie to talk about how they are applying the lessons learned during this phase of the 9 months of implementation into the next phase of the program going forward. Bonnie? I hope he's still there.
I'm still there.
Okay, thank you.
Yes, team, the facilitators and the team of Room 5. Installation learned from the projects WASH, EcoHeat projects WASH, which I've talked about first time at the beginning. We are applying the lesson learned in the SIDA projects. We are continuing with the community dialogues. These ones now, because of COVID, there's changes. There's no crowding here. So our target is just households, so 3 households, and this comprises of a session of 7 to 10 members only. I think I've explained because of coronavirus of 2019, which limits the number of people in the crowd. Then we are continuing with hygiene session, but we have also adapted and had a hygiene session at the health facilities together with the health expert. All these want to scale up the hygiene messages, the facilities. And at the same time, we provided TV sets to these health facilities to aid in scaling up hygiene messages to greater coverage. And this one, with our pleasure is that most health centers are being attended by the mothers of children who basically 5 years below they attend this, so they get that plus other crowd. This TV set will be used at health facilities. We are continuing with a community video, which is targeting only 30 participants, 30 people due to coronavirus, SOP, which we have to apply. By then we could do crowd, but still the same SBCC strategy. And on that, we are also continuing with a radio talk show and hearing sport messages. And to ensure radio listenership level coverage increases, we have provided radio sets to community leaders and some hygiene promoters. So they mobilize and form a group of 7 or a group of 5. They listen to the program. So that's how it has been a challenge in the HECO projects where listenership was not so much because availability of radio was not by everybody. So this time we provide the radio set to the community leaders and hygiene promoters for everyone to listen. On construction of latrines, we have clustered people. We have clustered 15 households to support themselves construct the latrines on their own. This is how we have made it. This clustering made also ownership. And under SIDA projects, we are supporting construction of 1,200 household latrines. These latrines are for lactating mothers, pregnant mothers, and caregivers of children 2 years below. Thank you very much. I think that's what we have. Action Against Anger. Thank you thank you facilitators, core, global core, health practitioners, and the rest. For any questions, I think they are most welcome. Thank you so much, our facilitator, Echo.
Thank you.
Back to the
Thank
facilitator.
You,
welcome.
Yes, I've been getting messages that our time is up, so I'm not so sure that we have time for questions.
Okay.
We could probably answer at the end of the session after the next presentation, right?
Okay.
Yes, once the next set of speakers are done, we'll take a few seconds. Since we have time.
Okay, great. Okay, great. So back to you. Let me stop sharing.
Thank you so much, Jonah and Robert, for that presentation. We would move on to the next set of speakers, who are all from the International Rescue Committee in Nigeria. They are Temitope Michael Oyelade, Amaka Oriva, Kezia Patrick, and Ibrahim Balami, who would be speaking on the topic testing ASRH intervention packages in a humanitarian setting in Northeast Nigeria. Ibrahim, over to
you. Thank you. It's really a great privilege to be here and to present on the work of the International Rescue Committee. So the presentation I'm having here is adolescent, they know best. This was actually an operational research funded by OFDA, and it's being conducted in Borno State, Nigeria, as well as in the Unity State in South Sudan. What is really worthy of note in this is that Borno State, where this project was implemented, was actually the epicenter of the Boko Haram insurgency. And it has over the years experienced high collapse in terms of the structures on ground, including the healthcare system. So including the healthcare systems. Are we together?
Yes, go on, Ibrahim.
Okay, so including the healthcare systems which are currently operating, and the little humanitarian organizations which we currently have on ground. Usually programming are not adolescent inclusive, and where they are available, the fundings for such projects are usually small and do not last long. So in terms of this operational research titled Testing Intervention Package to Improve Adolescent Access and Use of ASRH, for us it was a major breakthrough having this funding opportunity to run this. The objective of the research actually was to test 2 intervention packages, majorly aimed at increasing access, use, and the quality of adolescent sexual and reproductive health services in such setting, which is challenging. Also, to also explore how participatory action, just like ECF has used, to see how it can improve adolescent meaningful access and engagement in health programming and bring out better outcome. Then lastly, we wanted to see if we can have new learnings from this operational research and to discuss it in platforms like this. Moving forward, I would want to talk about the packages. We had 2 basic packages in which we were testing. One was the core ASRH package, which was majorly aimed at removing facility and community level barriers to accessing ASRH services. It has a lot of components involved, which we'll discuss later. Then the second package is called the Engage, Empower, and Act for Adolescent package, which was 2 packages matched at one, the core ASRH package, as well as a second package called the Participatory Action Research. The participatory action research component of the project was basically aimed at giving adolescents full ownership of healthcare service provision. So they were involved in the design of the program, in the implementation, in monitoring and evaluating the progress of the project, as well as in the writing of the report and documenting lessons learned. So this project was implemented in different locations within Maiduguri, and the results were accumulated. I would share link to more details of the results so that we don't take off much time here. So in terms of the implementation of the core ASRH package, there was a component of it which is called the values clarification and attitude transformation exercise, which we brought into the implementation of the project. And the VCAT activity were visually targeting to explore questions, clarify values and belief that are associated with sexual reproductive health, as well as gender norms in areas where such services are highly stigmatized and are usually not accepted. Then also the VCAT workshop was also to help us see if there could be an improvement in terms of adolescent seeking behavior toward ASRH services, which has high demand. as well as if there could be a transformation in terms of the attitude of service providers while providing services towards adolescents, because we believe that if there's a comfortable environment for adolescents, these services, to access these services, adolescents will actually want to run into and access more of the services. So the VCAT exercise was imputed into all of the aspects we deal with, starting with the training, be it for health service providers or for community.
Hello, Ibrahim. We are a bit time constrained, so we will appreciate it if you could wrap up so the next speaker can speak within the 5 minutes, please, so we can have more time for questions. Thank you. Ibrahim, sorry, you're muted.
So it was, the VCAT exercise was included in all of the implementation, including the trainings, as well as supportive supervision and arranging their facilities to make it more friendly for adolescents to access. My colleague, Dr. Oreva, will speak more also on the VCAT and give us a practical experience of how it feels. Thank you.
Thank you so much, Ibrahim. So like he said, the VCAT is, it means values clarification and attitude transformation. It is an exercise that is aimed at exploring and reflecting on the comfort levels of participants in discussing, advocating for, and providing adolescent sexual reproductive health. So we're going to have a brief glimpse into it. Ideally, this is done in person. For example, the one we're going to be doing now is adapted from the IPASS exercise, which is Cross the Line. It gives a visual overview of how each person views certain opinions, and it makes each person see how many more persons have similar opinions as them. So, but we're going to be doing this online briefly. And so we're going to present a question, and I'd like for volunteers to please drop their opinions in the chat box. So here you have a question. Educating adolescents about family planning will only encourage them to have sex. Do you agree or disagree? Kindly drop your opinion in the chat box now, please. Okay, this is beautiful. Thank you. So I can see that the general opinion is disagree. So I'm going to be calling on my colleagues to give a simulated opinion about this, just so we have a taste of what it's like. So I'm going to call on Keziah. Keziah, what do you think about this question? Do you agree or disagree? Okay, Dr. Tope, can you give us your opinion on this question?
Thank you. I disagree as well, because studies have shown that giving adolescent information about SRH does not necessarily make them to have sex. And then moreover, giving them this correct information can prevent them from harmful outcome. Whether you give information or you don't, this thing still happens. So such harmful outcomes such as unintended pregnancy or STIs can be prevented if you give information. So I disagree. Thank you.
Okay, Keziah, what do you think about this?
I actually agree. In my community, once girls know about where and how to assess family planning, they start having sex because they think there are no consequences and they can do what they want. So it is and people have to be careful. So it is better to give them information after they are married.
Back to you, Amake. If you are speaking, you are muted.
Oh, sorry. So I was saying that this gives a glimpse into what the VCAT looks like. I'm waiting for the next question. Oh, yes, here it is. So 14 is too young for a girl to have sex. Agree or disagree? What is your opinion on this? Could you drop your opinion on the chat box, please? 14 is too young for a girl to have sex. Thank you so much. So I can see almost everybody's agreeing. Dr. Sope, do you have an opinion to share on this?
Yes, I actually feel just like everyone that 14 is indeed quite young. But we see in many communities here and even elsewhere that the reality is girls still have sex even at that age. So sometimes it is consensual, sometimes it is due to harmful practices such as early marriages where they don't even have a choice. So we as public health professionals, we need to just understand the reality of the context, demonstrate a non-judgmental view, and remain prepared for any scenario we find an adolescent client in. Thank you.
Thank you so much. How about you, Keziah?
Okay, so I don't need to be always on the disagreeing side. So in this scenario, I agree that we have to be non-judgmental. But there are negative outcomes that result when a 14-year-old girl has sex and, for example, becomes pregnant, She faces much higher risk for complications during pregnancy and childbirth. So with that in mind, I feel torn about how to respond. Thank you, Aurora.
All right, thank you, Zaya. So now this has given us an idea on what the VCAT looks like. This VCAT, we use it in a lot in this research and also in trainings with the community, with clients, with service providers, just so we have, they can explore their attitudes and there could be improvements where necessary. Thank you. So I'm going to give this over to Keziah, who is going to be taking questions from everybody. You have questions, please, should take this. Thank you.
Thank you.
Hey, everyone. Yeah, if there is question, we entertain one or two because of time, and we hand over to the presenter. I'm waiting.
Yes. So kindly send your questions to the chat box and we will get to you. Thank you so much for the presentation. Okay, so we are going to read some of the questions that were asked. And the first one was from Elsa, who was asking how many people were reached with the survey and what is the rationale for latrine provision for mothers, pregnant women, etc. This is in relation to the first presentation. So Sona, if you are
yes,
on, I appreciate if you can speak to it.
Yeah, thanks, Seko. If Bonnie is here, maybe he can respond to this one. The number of people in the post distribution monitoring survey, and I think I'll quickly respond to the other question about the need for latrines for mothers, right? So it's actually part of the. I'm sorry, I'm getting some message that says start my video. I don't need to start a video. So okay, sorry, I think that's what was meant. So in terms of latrines for pregnant women and mothers of children under 2, it was part of the babyWASH initiative because the hygiene and the water and sanitation and hygiene for children is something that was attempted in as part of this project, and which is why mothers of children under 2 and mothers and caregivers of children under 5 were part of the target audience. Bonnie, are you here? Do you want to take the other question on the number of people in the post-distribution survey?
Yes, I would like to take the
and
question.
You can add to the answer. Yeah.
Yeah, I can add on to the last question as well. Thank you, the moderators. The question number of people involved in the post-distribution survey. So the survey was done actually it is always done after distribution, and it was done at a consortium level and was led by the Danish Refugee Council. So it is a quarterly activity. So every quarter, a consortium lead take leads and move and ask questions and people's response. So by now, I don't have the figure. As I said, the lead was DRC. So it was quarterly activity on post-distribution. They ask about the distributions, how people are feeling in cash. It was the many components, DRC, handling both wash and cash. In a consortium, we're also having LWF that were also handling cash distribution, this cash distribution to the PSNs who we are supporting with wash intervention. So by time, I don't have figure for that because it was a joint consortium led by DRC. Then I would like to add a bit on the why we are selecting, supporting one of the mothers, the lactating, the caregivers of children 2 years below. Yeah, ACF major intervention is to address the causes of malnutrition. So that is the core intervention of action against hunger. So most of our interventions are triggered toward addressing cause of malnutrition. And majorly the people affected with malnutrition are children at least below 5 years. And so even wash intervention, it target that, we ensure good hygiene. Even if you are receiving food, now food from WFP, but if there's no hygiene, we cannot address undernutrition. So that's why we have to address the malnutrition right from the womb. Have to at least 2 years and above for the CEDA projects. We believe the child can now grow well. And that's what I wanted to add. And in the previous survey, there's a survey also conducted under ECHO I did not mention. There was issue of handling children feces and hand washing. So ACF also took this as one of the key focus to address the issue of proper handling of children feces, hand washing, and targeting those families with children below 2 years under CEDA, under ECHO was below 5 years. I think that's what I can add for now. Thank you, facilitators. Yeah.
Thank you very much. We have roughly 7 minutes to wrap up this session. So I will take one more question and then we end the session. Naula wants to know, wants to know, this is to the IRC team, how or what unique challenges were faced when engaging adolescents in the CAL VCAT approach that weren't experienced when dealing with adults. So if someone from the group.
Yeah, hello again, guys. We have been, bullied, we were taken to court, there was that misconception we were making the adolescents to be promiscuous. Actually, a lot of challenges, but at the end, we were actually able to scale through. So from the religious leaders, from the cultural leaders, like, oh, what are they doing? Are they trying to teach our young, boys and girls how to have sex early, because here in the part of the world, like it's almost a taboo to talk about sex to adolescents. So most times it is left, at the grace of being married. So that was why we really, really hammered on the values clarification. Thank you, Noka. I hope this little contribution of mine answered your question. Meanwhile, Ibrahim can add up to it. I can see him talking, but he is muted. Ibrahim, do you have an ad, please? Sorry, guys, silence is an answer. Thank you. Ibrahim doesn't have anything. Over to Echo.
Thank you very much, Celia. Christine also has a question. How long would effort towards WASH continue in order for the behavior changes to be permanent and sustainable? If that is for the first presentation. So if Sona or Robert could answer to that very quickly, so we wrap up the session. Thank you.
Sure, I will start as usual, and Bonnie, you can add on to it. I think that's a bit of a problem with social and behavior change interventions. One is never too sure. There aren't any quick fix solutions, and there aren't any identified time period that any intervention can take to make a sustainable change. But I think it all depends a lot on how it is implemented, and whether or not we are only trying to increase knowledge and providing information, or are we focusing on changing behaviors? And I think we saw in the 9-month period that this project was implemented, we saw quite a few changes that happened already. For this to be sustainable, I think it also requires an approach that engages the community right from the start, for even looking at local solutions. So that would be my response to it. I'm sorry, I'm not able to give you a definite number of years, which I don't think is feasible to do. Bonnie, do you want to add to that?
Okay. Thank you so much, Sona, for that.
Okay. Hello?
Yes, we can hear you.
Yes, I would like to add to Sona on the sustainability of that, what we have been providing. We have the sustainability plan. We are involving the government. So every stage of intervention, the social behavior, including even the development of the SBCs, we involve the government, respective departments of health and WASH to this. And currently we have village health team. Those are structure of the government who are following up the continuity of the behavior. And they also have in there, they incorporated in the program of the government. In Uganda, we have sanitation programs, which they continue running the radio spot messages, continue conducting radio talk show. So the messages are continuously being aired by government hand. For those one who are now, we are not supporting that. For those one who are supporting as well, as part of the projects, we keep on telling them, adapt the behavior, time will come, SCF will leave, but we want you to leave, we leave, but want you to continue. So we keep on sensitizing them to adaptation versus SCF leaving or leaving due to end of projects. So we have the sustainability plan, government, and our own sensitization. And all those dialogue meetings with the leaders in the community, all those dialogue meetings also to address the issue of sustainability. Thank you. That's what I would like to add.
Thank you very much, Robert. And all too soon, we've come to the end of this session for discussion. And I'd like to thank all the speakers for their presentations, because through that we've been able to learn some of the impacts of the WASH project and some of the ways that the International Rescue Committee members are working in Northeast Nigeria to engage adolescents on ASRA. So as we conclude this session, please head back to the conference website to join the marketplace session. Thank you so much, and we wish you a very lovely week.